So we approached Nottingham and Professor Ahmad Raka about 2 years ago to say that we were looking to show that there was potentially a better way or a different way of detecting HER2. And this came off the back of TDXD. Very generously, he gave us access to his very large selection of samples. And these samples that we're going to show you, the data we're going to show you here, is from samples that were collected between 2012 and 2017. So they had a long period of follow-up. So we were able to add the follow-up clinical data to the mammotyper data as a differentiator for who was right, who was wrong, I guess you could say. So we'll start with, obviously everyone knows, I guess, in the room that the HER2 positivity is defined firstly by immunohistochemistry and then with FISH in the case of 2+ samples. The issue came about in HER2 testing when TDXD came to the fore and HER2 low became this new de facto group that we'd never before had to look at, that this test itself arguably wasn't designed to find. And so there was the rushing around of, can we define HER2 low using immunohistochemistry? Can we all look at the same slide and see the same thing? And that didn't go so well. So the study was really to see if mammotyper could help fill that gap in defining the HER2 low group. So it was a total of 350 patients. These were patients, again, so they were slightly historical samples, and some of the patients had been treated just using chemotherapy, and some of the patients had been treated using chemotherapy and trastuzumab. To be clear, these are all HER2 positive patients by immunohistochemistry FISH. So some of them are 3+, some of them are 2+ FISH positive. So all 350 samples were, by the time they got down to the tumour content and availability, obviously the age of the sample, some of them, the RNA wasn't quite good enough. They were 10, 15 years old. We got down to a total of 287 samples, which gave us 128 in the cohort treated with chemotherapy alone and 159 in the trastuzumab treated category. You can see on the right-hand side there was a reclassification. Again, all positive samples on the left-hand side, predominantly positive on the right-hand side. A couple were reclassified to triple negative. 38 of the samples were classified as HER2 low, HER2 negative by mammotyper. And so then they then started to look at how that corresponded to the outcomes for the patients. So there's a lot of data here to look at. But if you look at it, the top plots there are the mammotyper response to treatment. So you have your blue line, which is the chemotherapy only, and then the green line, which is the anti-HER2 trastuzumab treated. So what you would always expect to see is that those not treated with trastuzumab would have a poorer outcome, whether that's distance-free survival or metastatic. But you would always expect to see a difference between the treated and the untreated. What we saw with the mammotyper results, and this was predominantly, again, because of the reclassification of positive patients to HER2 low, HER2 negative patients, there was a greater differentiation. It's all about the P numbers, they tell me. So if you look in the middle graph, I haven't got a pointer, but the middle graph at the top there, the P is 0.003, and the graph below it for IHC is 0.013. Now, 0.013 is a very good differentiation. It shows your drug is working. But 0.003 is significantly, statistically more defined change. So it basically what this data alone shows is that mammotyper was better able to define who would respond to anti-HER2 therapy and who wouldn't. What they then did is take those 38 patients, I think it was, and look at how individually those 38 patients responded to their therapy. And what's even more interesting, what was interesting for me is, again, you would expect to see always that the Herceptin-treated arm would respond better, have a better distance-free survival than the untreated arm. In this very small cohort of patients, actually, the patients treated with Herceptin maybe, and again, I'm sort of guessing here, but they were treated, on an assumption that they were HER2 positive and therefore would respond and weren't given secondary, third lines of treatment. Their survival actually wasn't any better. But at a very basic level, looking again at our P numbers, a P of 0.24 means that statistically there was no benefit to that anti-HER2 treatment in patients, again, who this is patients from Ahmad Raka's patient group, very well respected. The guy is co-author of the pathology guidelines, wrote 8 of the chapters in the book. So these were tested using best-in-class HER2 testing, and these patients didn't respond to the therapy, even though they were prescribed as HER2 positive. So the conclusion that they came up with was that, and again, this will move on to further data, is that Mammotyper offered the opportunity to be a promising companion. And again, we talk about where does Mammotyper fit in the grand scale of testing for breast cancer or subtyping. Right now we have IHC and we have FISH. Between the two of them, they've done a good job, but a lot is being asked of them. And the aim is that Mammotyper can add an extra layer of information, and therefore it gave a positive outcome in terms of response to anti-HER2 therapy.